Dr. David Thiel. He's a professor of urology. He's also a chair of the Department of Urology. He last year received the Distinguished Educator Award from Mayo. He's got 2 lectures for us, one on BPH and the other on the management of urinary calculi. Dr. Thiel.
Thank you, Tom and Mike, for inviting me. And I think yearly you guys put on a great course here, and one of the gold standard courses that Mayo offers. So let's start out with a couple questions. We have a 68-year-old healthy white male who's got 6 years of worsening voiding dysfunction. His PSA's always been within normal limits. He's never had urinary tract infections. He doesn't have any upper motor neuron problems such as Parkinson's disease and so on. And his AUA symptom score is now 16. With regard to that AUA symptom score, would you say 16 means he needs treatment? B, 16 means he needs watchful waiting, do nothing? Or C, 16 really doesn't matter that much, it's how he feels about it. So he wants to know first, before he does anything, is there any modifiable risk factors in his life that can help with this? And you tell him, no, it's going to get worse with aging, because we see men in here all the time, and as they get older, this gets worse. B, actually, if you lose weight and become more active, it'll help you. Oh no, it comes with aging, and medicines are the only thing that are going to make you better. Eventually, he gets alpha blocker therapy, and that works well. His AUA score goes down to 8, but he doesn't like the retrograde ejaculation he's having. He wants laser surgery, and you tell him, good, laser prostatectomy is the gold standard BPH operation. Or laser prostatectomy will help you, let you come off the medication, and get rid of your retrograde ejaculation. Or laser prostatectomy is an option in certain patients, but TURP is still the gold standard, and surgery for BPH carries the risk of permanent retrograde ejaculation. So, BPH occurs in about 50% of 50-year-olds and about 90% of 90-year-olds, so it's very common with aging. It does have an economic impact in the private sector. Men in the private sector with a claim for BPH spend about $1,500 more than those without BPH, and they tend to miss about a day more of work than those without BPH, which gives us a direct and indirect cost to the population of close to $4 billion. When you look at those one-year disease-specific costs, that's up there with diabetes and reflux. So it is an impactful disease that you see a lot of out in the community. The pathophysiology is as simple as it sounds. We get BPH, benign prostatic hyperplasia. That gives us bladder outlet obstruction. That eventually leads to lower urinary tract symptoms, which eventually can lead to urinary tract infections, urinary retention, stones, renal failure, and so on. Are there modifiable risk factors?